Okay, folks, welcome to our next session. This is Enabling Action Beyond Payment Reform, Advancing System Transformation Through Accountable Care. My name is Jeff Micklos. I'm the Executive Director of the Healthcare Transformation Task Force and also a co-chair of the Accountable Care Action Collaborative. For those of you who may not be familiar, the ACAC is part of the LAN. It is a force multiplier for the LAN by extending the LAN's reach and ability to impact the entire industry. The ACAC is comprised of 32 umbrella organizations that are sharing opportunities to share what they're doing in the value-based care space, as well as disseminate more widely the learnings of the LAN. Payment is an enabler of value-based care, but it's just an enabler, right? There's different ways to think about how we define success in value-based care. And so we're going to do that in this session. I was asked by the LAN operator team to comment, though, on some recent events. So as we get here together, I've been coming to these for a long time. I think of them somewhat as a therapy session. You should all give yourselves a hand. You're doing great work. And there's been some data points out this year that supports that's moving in the right direction. So if we think all the way back to March, there was a letter that went from the Congressional Budget Office to the Senate Finance Committee and the Budget Committee. And it showed that there has been certainly a flattening of the cost curve. And although they couldn't quantify it, they pointed to care coordination and work being done in diabetes and in hypertension as contributing toward that. I read that report saying, hey, all you researchers out in the world, continue to look closely at this. We need to better quantify that. That got a lot more focus in September. You may have seen a New York Times article that talked about how there was $3.9 trillion in savings over what was estimated for federal health expenditures in 2011. $3.9 trillion. The funny part about that article is they said, we don't really know what it is. Well, it's a variety of things. But for those of us who live in this space, we were disappointed that value-based care didn't get a call out there, and it should have. Thankfully, those authors at the New York Times wrote a follow-up article, and also thanks to Zeke Manuel, we got value-based payment and value-based care on the map there. So it really is an important time as we focus on going forward that what we're doing are changing things. But it's not all about saving money necessarily for the federal government. It's about smarter spending, and smarter spending is not always lower spending. It's nice that we're doing both. We're improving care, and we're reducing and contributing to bending the cost curve. So something really important to highlight as we move into this session. I am thrilled to be joined by a panel of experts. Perv is doing double duty here, 2 in a row, and some other health plan and a provider colleague as well. So to my left, Purva Rao is the Chief Strategy Officer at the CMS Innovation Center. Then we have Leora Horowitz, Director of the Center for Healthcare Innovation and Delivery Science and Professor at the NYU Langone Medical Center. Matthew Fox, Senior Director, Health Policy and Value-Based Payment Strategy at UPMC Health Plan. And Gosha Silvestric, Associate Vice President, Humana Healthcare Research at Humana. Thanks all for joining us. So we're just going to go right down the line here. Really want to start off with a kind of an opening softball a bit here. Please share a bit about your organization's approaches to defining success in your particular organization's payment and beyond.
I can start. I'll take a softball after the last session. So I'll just speak just for a couple of minutes, a little bit about our structure at the Innovation Center, and then where we want to head in order to get a little bit deeper beyond payment to some of the care delivery changes and transformations that are happening on the ground. So first I'll just talk a little bit how we're structurally equipped to do this, both in terms of the groups that we have at the Innovation Center, but really the experts and the expertise that powers our work. And the first is our Learning and Diffusion group. Kate Davidson is a familiar face to many of you. She leads our Learning and Diffusion work. And there we really have a capability around building learning systems around our models that really help model participants through the journey of being in a CMMI model, understanding hopefully what's working, what's not working, and then sharing and disseminating best practices. And that's also complemented by our evaluation group that's run by Noemi Rudolph, who's also here today. They not only design our evaluations, but oversee the execution of our third-party evaluations. And so those are really the experts that are powering our learning and our evaluation capabilities, which are really, I think, the foundation of what we want to be able to do moving forward. And there we are developing a new framework around transformation and how we can build on our learning and evaluation capabilities to start to not only understand what's happening in models, but what's working and what isn't working and under what conditions. And I think that's really where we need to go to be able to accelerate meaningful care delivery transformation and change.
Great. So I know the remainder of our panel, we were talking in the green room that we were going to drill down a bit for you here and get into some specifics about what they're seeing in their individual organizations. Leora.
Yeah, well, so I represent the healthcare provider group here on the stage. And I work at NYU Langone Health, where I run the Center for Healthcare Innovation and Delivery Science. And I would say that at NYU Langone, we define success, I think, really in two ways. So one is fundamentally results. We are extremely proud of being #1 for quality in all kinds of different measurements, and quality is really at the core of what we define success as. But the other way we define success is whether we are a learning health system. Are we embedding best practice as part of routine care? Are we aligning culture and incentives and technology? Are we generating knowledge as a routine byproduct of our everyday care? That for us is success. And so if we have time later, I'll tell you all kinds of stories or examples about how we do that in actual life. Like, how do we in fact learn from what we do every day? How do we change what we do the next day based on what we learned the prior day? How do we continually iterate and improve? For us, that's really what success is about.
Matthew?
So I'm coming from UPMC Health Plan, part of a larger integrated delivery finance system that is UPMC. So success for us, I think, is kind of rooted in that being our identity. A large part being trust we build with providers that are directly UPMC employed or otherwise in our value-based payment arrangements. And I think we leverage our IDFS character in that sense by incorporating providers very early in the learning stages of developing value-based payment and alternative payment models. And that means more than just inviting them to a Zoom call and saying, here's a new care process that we thought up. What do you think? It's kind of actually going into their practices before we even have an idea and trying to understand, exactly what the situations are, boots on the ground, and making sure that our programs are speaking to their needs and the needs of their patients, and not so much the needs of the health plan only. And again, being an integrated delivery system helps us convey that message a little bit easier to providers because we both are aligned financially when our patients succeed.
Thanks, Matthew. Gosha.
So I sit within Humana's healthcare research organization, so it's a little bit more of that traditional kind of approach to evaluation and kind of trying to bring our findings out into the public domain. But there is also a new arm that we have been really building within Humana that's a little bit more focused on rapid learning and kind of setting up those, I'm sure other panelists are working on the same thing, setting up on more of those rapid learning capabilities. But I think both parts of the organizations are really, focused on the same kind of thinking about success metrics that go above and beyond what we typically looked at. So not just looking at, utilization of primary care and going beyond looking at, who's using the primary care, do we get the right population to use it? Trying to now expand what we've learned about the primary care utilization to understanding how it translates into longer term avoidance of maybe unnecessary acute care. But more and more frequently, we now are also thinking about those diverse perspectives from other stakeholders and measuring that. So thinking about physician burnout, so trying to study how we can, how we see changes in physician burnout as our providers are moving across the continuum of different payment systems. And also increasingly, which is really, it's really great to see, increasingly trying to get additional outcomes and be able to quantify the patient perspective and how patients perceive what we call value-based care. Do they even notice that they are in that type of payment arrangement? So trying to kind of move away from the typical things we've been looking at for a few years now and trying to expand it to trying to more fully capture the perspective of different stakeholders.
Great, thank you. So let's go ahead and mix up the order here a little bit. Matthew, I'll come back to you. So in your work so far, what interventions have you found to be most effective and which also speak to the most to increasing utilization of preventive care?
Right, so, as I mentioned, we're an integrated delivery finance system. One of our, offshoot organizations is a UPMC Center for High Value Healthcare. They regularly do clinical trials research, grant funding opportunities, what have you. And hope everyone's not sick of hearing about e-consults, but that is one of the more promising areas that we've received learnings from the UPMC Center for High Value Healthcare, specifically the Insurance Services Division where I sit, and the Health Services Division, the other provider arm of UPMC, put together a pilot where the intent was to allow to give primary care providers more time in their schedule. One thing we saw was a major constraint on that time was time needed to meet and manage patients with diabetes. So we worked with our analytics team that sits on both the Health Services and Insurance Services Division side and developed these patient identification algorithms using machine learning, which essentially, we had an endocrinologist sitting and, mining claims data from the insurance side, looking at patients that would be seen, or were about to be seen by a primary care physician, and they were providing targeted, automated electronic consults. It's easy to remember, tacos. You can Google UPMC, and that won't just give you a place to eat. So essentially, as opposed to normal e-consults, the tacos approach we have implemented is automatic. So the endocrinologist automatically sends a best practice alert or a clinical decision support type alert to the primary care clinician one day exactly before that clinician is supposed to meet with a member. And it provides a recommendation about, based off of our algorithm, this member is predicted to worsen in their ability for glycemic control. And that was actually, implementation was a big part of that because, we needed to ensure that our primary care providers knew what this alert was, where it was coming from, that they could, it was a trusted referral from an endocrinologist. But also another important part of that program is they had the ability to reach out to that endocrinologist that made the recommendation. And we've seen great success with that program. About 75% uptake of the recommendations that are sent to primary care providers. And for those 35% where the uptake wasn't there, it was mainly due to reasons like the patient didn't show up for the appointment or they were excluded because of the type of insurance they had. And we've seen a lot of success in terms of ability to control total medical spend. But we've also learned a lot, as I mentioned, about rolling out this initiative. How do we convey it correctly and appropriately to primary care so that they utilize the recommendation. But then also from the endocrinologist side, how do we think about, we're asking specialists to do things differently. How are they being paid for this e-consult? How does that fit into their schedule? So those are all things I think, again, being an integrated delivery system, we're able to kind of see both sides of the value-based payment arrangement. And that's given us confidence to roll that out more broadly, but also think about other specialists and other specialty types where engaging a primary care to practice at the top of their license or not refer out when they were not fully confident in their ability to manage the patient. We're looking at more opportunities beyond just endocrinology right now.
Great. So Leah, I'll come to you. You've published in the New England Journal of Medicine on the learning processes at NYU, Langone. Can you speak to your experiences there and also some of the interventions you have found to be the most effective?
Sure. So one of the components of our work at NYU is that we have a rapid cycle project lab. We used to call it a rapid cycle trial lab, but that upset our IRB. So now I call it a rapid cycle projects lab. And the reason we call it projects is because they're all sort of quality improvement work. They're not randomized trials of drug A versus drug B, but they are efforts to make everything that we do operationally testable. So 95% of the stuff, 99% of the stuff that we do in the health system, we just do because it feels like a good idea. Like seems like a good idea to call people post-discharge, and it seems like a good idea to send them a nice message after they've been to the outpatient doctor's office, and it seems like a good idea to put up a poster recommending a flu shot and whatever. But we have no idea if any of that works, and some of it is really resource intensive. So we have a whole group that is embedded within the health system, within our care management, within our IT, within our patient experience groups, within all of the clinical areas, and we partner with folks to just test whatever it is that people are thinking about doing. So I'll give you just one set of examples. So we, like everyone, we are doing population health management. We are trying to make sure that our patients are getting their routine health maintenance and their mammograms and colonoscopies and so on. And so we have a whole call center that calls them up and says, hey, you haven't been to your primary care doctor this year. Can we make an appointment for you? And relatively few people say yes when we call them up on the phone. So we took a look at the script, and we noticed that it took like 10 sentences to get around to the why are we calling you part. It was, hi, I'm calling from NYU. We want to make sure you're doing okay and that your health record's up to date and see how you're doing. It was like lots of stuff. So we did some randomized testing of alternate scripts. And the first couple that we tested were not any better, but finally, after multiple iterations, we got to a script that was both much shorter and much more effective. And so then we implemented that across the board. But then still, we have too many people to call. I mean, we can't actually call all 6 million of our patients all the time. So we wondered who, with our fancy new script, should we be calling? Should we call people who usually get their mammograms and maybe just need like a little extra nudge? Or should we call, or would they get it anyway, and that's a waste of time? Should we maybe call the people who never get their mammograms, but maybe they just don't believe in mammograms, and there's no point in calling them at all, right? It's not obvious up front. So we figured out who was most likely and least likely to get a test on their own. We randomized them in those risk groups to getting a phone call or not getting a phone call. Remember, we couldn't call everybody anyway, so we were not depriving anybody of anything. We were just making the randomness that we were doing before actually random. And we found, in fact, that the people who were least likely to get things on their own were most responsive to the phone call. So now, at the beginning of the year, we just sort everybody in order of how likely we think they are to get the thing on their own, and that's the order that we call in. So we are much more efficient with the resources that we have. And then the third thing we did just recently is we thought, we have a whole patient portal. We don't really have to call everybody. Maybe we could just send a message, patient portal. Would that be as effective as a nice personal touch? And so we randomized that too. And so we are constantly testing what we are doing with our regular healthcare operations so that we ultimately get to points that are much more effective, that reach more people, that get us to the outcomes that we want.
Great. So Gosha, we'd love to hear about humanist perspective to rapid cycle learning and evaluation, and maybe also add on a new question there to say, how do you view kind of using those lessons learned to be able to advance initiatives and even toward an eye toward multi-payer alignment?
Yeah, I think we're still building those capabilities. I mean, I'm hearing some of the same stories, definitely, Leora, that you are talking about. But I think we're really early still in figuring out how to do it really well. I think we're because we're focusing a lot of times on like end outcomes that take a long time to observe, we're running into the problems of some of these tests and some of these pilots taking us maybe 2 years from the beginning to end. And that obviously starts to like create a little bit friction. I think getting into a little bit of like philosophical debates sometimes about doing prospective work versus retrospective work, and where the value of each comes in. So I think we still have a lot to learn, and I think we're learning. I think this is also not an uncommon problem. I think other payers are also increasingly setting up these types of like behavioral economics nudging shops, and I think like as we all grow those skill sets and figure out best practices, things are going to get better. But I think still early in that process. And you have to repeat the second question.
How that can inform multi-payer alignment type strategies?
Yeah, I think the interesting, and this was coming up in the earlier sessions, I think the interesting kind of perspective on the alignment is that part of like what's interesting of being at the on the like private payer space is that you can observe a variety of implementations, and I think earlier speakers were talking about that. You know, like it's good. We do need to have some alignment, but on the other hand, there is a lot of experimentation and different models that are happening. You know, in the payment innovation at each of the payers. So I think like the way we're thinking about it in terms of like what research can do, what my shop can do to help with that, is just kind of do the best we can at documenting the things that we're experimenting with at Humana, have really good stakeholders in those evaluations. So we typically partner with academic institutions. We have great collaborations with Harvard, with Penn, with some local universities to try to help figure out what that kind of best multi-payer alignment might be, and just kind of like from my perspective, where my shop is, like trying to help with that kind of like idea generation and evaluating of the ideas that we bring to the table.
Great, thank you. So Purva, the Innovation Center has been engaged in a very kind of intense analysis of your evaluations, and we've discussed with the task force and the Innovation Center that idea of success metrics beyond payment marks. And so you've obviously just published a really important paper in Needs and Catalyst, really setting forth how you think about things at the center going forward. So please share more about the research itself and how you're thinking about things at the center going forward.
I mean, I'm excited about this. I think all of this has its roots very early in our strategic refresh in 2021. We announced a new strategy, for a refresh strategy for the Innovation Center, and one of the things that we talked about was how do we assess the impacts of our models, and I don't want to say just success, but the impacts of our models more broadly on people, on the providers that are delivering care, on the health system more generally. And one of the ways I think we've come to start to think about is what is the Innovation Center's role in really supporting a learning health system. We've actually spoken to Leah and other experts across the country about some of the work that is going on externally, so that we can better understand how are people starting or trying to get at what's working and what's not. As part of this effort internally, you alluded to the fact that we've been undertaking kind of intense effort that was really, again, led by our learning and diffusion group and our evaluation groups to cull through a decade's worth of evaluation reports. We do a lot in our evaluations. Oftentimes, we have usually use like mixed methods now, methodologies. We have a lot of qualitative analysis that we also do as part of our models, and really went through to ask ourselves, and it wasn't really a paper then, it was really to inform this framework and really how we want to get a little bit deeper on the care delivery changes that are occurring. So we started to go along, and I'll kind of summarize some of the main points from what we found. We thought it would be important information to disseminate more broadly, because I think what we saw is that a lot of transformation happened in our models, a lot of care delivery changes happened in our models, and we saw clear patterns. But what we couldn't get to is what worked and what didn't. And I think that's really what sets us up for this next phase of what we want to be doing as part of our transformation work and accelerating delivery system change and transformation more broadly in the health system. But some of the themes that we heard are probably not going to be maybe a surprise to many of you that have been in this space for a long time and are doing the work on the ground, but I think it's really important for us to be able to pull information like this together, publish it, and really start to have a broader and deeper conversation about what value-based payment is enabling on the ground. So one of the, there are three main themes. The first was a lot happened around care coordination within and across models, whether or not it was a requirement in models or not. And the way that this played out was, number one, we saw consistent provision of team-based care across our models. So one example, in our CPC Plus model, we saw that over 43% of practices were reporting formal, team-based reviews of high-need patients. And then in our qualitative interviews and site visits, we're also picking up that there were also more informal discussions going on around the team and around patient needs. The second is patient navigation. We saw this consistently across many models as well. And then the third was more targeted care management. So participants, depending on if they're a practice or an ACO or, were using different techniques, but they were generally trying to risk stratify to identify those patients that were going to benefit from deeper levels of care management and support. So that's sort of how care was changing and probably was felt differently maybe by a patient or a beneficiary. The second aspect that we looked at was something changing for providers? I think this is a really important question right now, especially when we look at high levels of workforce burnout and stress. That value-based care should be enabling greater flexibility on the ground for providers to deliver care in the way that they think is best for their patients, and not necessarily just driven by codes and what's reimbursable. And so here we saw providers reporting that they had greater flexibility in many models to deliver care that was more tailored to patient needs. They also reported pretty consistently that they were able to make use of a lot of the data that CMMI models were providing to drive quality improvement. One example was in the next generation ACO model, routinely saw ACO setting up analytic capabilities, data warehousing capabilities to do things like identify patients that needed annual wellness visits, that needed preventive screenings, immunizations, et cetera. Really, again, using those data and capabilities to deliver hopefully high value and preventive services. And then the third was provider relationships. And among providers, they were reporting in many cases stronger relationships, even with those providers that weren't in models. So one example was one of our kidney care models. Nephrologists that were in the model were actually reporting stronger relationships with vascular surgeons that weren't in the model, but were important parts of the patient journey. And then the third is broadening out again from the patient, the provider, to the healthcare market. We also saw that our models were associated with spread beyond just, again, the patients that might have been attributed or aligned to a model and the providers in the model. And there's one concrete example here, and there was a great study that was published, I think, just last week on the Million Hearts model that targeted high-risk beneficiaries. We saw that a lot of the quality outcomes that we're continuing to see for those high-risk beneficiaries that are, the focus of the model, we're seeing similar quality outcomes being sustained in medium and lower risk beneficiaries. So that's just an example of spread beyond the model. So that's kind of top level, some of the findings from the paper. We think it's an important piece of starting the conversation around not just here's what's changing on the ground, but now how do we get from knowing what's changing to starting to really dig into and figure out what's working and what's not.
And if you haven't seen this paper, I really just commend you to read it. It's a really important framework. My organization, the task force, we just started our 10th year, and I remember my first board meeting in year 2, where we also established a payment mark target, just similar to the LAN. We have 75% of our business in value-based care by 2020, which we extended to 2025. And I'll never forget that Elliot Fisher said, we have to go with this now, but there's still going to be the so what test. Even if you get to that payment metric, so what? Have you really changed care for patients? And we knew we needed to do the hard work to be able to define what that looks like. And I think this paper really kind of solidifies a lot of important work. So thank you for crystallizing that. Lenore, you also talk about kind of that learning health system requires culture change. Can you talk a little bit about what went on at NYU Langone to kind of realize the potential of where you want to go?
Yeah, I mean, I think just like Purva said, so many of these sort of on the surface changes require so much beneath the surface culture change and infrastructure change. And one of the things that we learned immediately is that 90% of the stuff that we do doesn't work. So as soon as we started randomizing things, we were not seeing any benefit to most of the stuff that we were doing. And so that could have been really bad, I guess. I mean, that could have been very demoralizing. But we went in we kind of expected that might be the case, so we went in with a very sort of opportunity-focused look where we said, listen, we want to be a kind of place that's learning all the time. Let's test this thing that we're doing. Oh, it doesn't work. That's great. That's an amazing opportunity for us. Now we can stop what we're doing and really think about it. We don't have to waste our time, for example, calling all of our patients post-discharge, which we found made absolutely no difference to their readmission rate or even their satisfaction with the health system. So we said, okay, well, now we feel good about pausing that, and maybe now we can call the high-risk people twice, or we could spend a little more time, or we could change what we do with our phone call, or we could do something different because we know that what we're doing now doesn't work. And it created this culture of adaptability and flexibility and openness to change and sort of enthusiasm for evaluation and performance that's really special. And so so creating this kind of learning health system environment is a fundamental change to our entire culture at the institution. And we are now really pretty inundated with people coming to us all the time. We don't go out and look for projects. People come to us and say, hey, I want to start this new thing. Can you help me, test it so that I know if it's working? And so that, and they also know that they need to stick with things and iterate them and do things over and over until they get right. So, I think the value of so many of these models and so many of these programs is that in order to get to that end payment goal or quality goal or what have you, you need so much underneath, so much infrastructure that then bleeds over into so many other parts of the institution. So it's really a more general change.
Thank you. So Matthew, returning to the idea that the payment model is in service of care transformation, can you talk a little bit about your perspective on what the prospective payment options offer in that regard and how UPMC has been able to take advantage of the flexibilities to test some innovative strategies?
Sure, thank you. So yes, we do have a few prospective payment models or payment models with prospective elements, one of which is similar to comprehensive care for joint replacement or hip or knee replacement bundle that we're testing right now to examine whether the same kind of risk adjustment components and blended inpatient and outpatient target price that we're seeing and are testing in CJR are applicable in a prospective bundle. But I will say, it's not always so clear that moving to a prospective payment basis is always the most appropriate or right thing to do. For providers with smaller patient panels or specialists that treat conditions with adverse events that are very costly, sometimes it may not be the best approach for them to work towards a prospective payment type of model. So that's another area where we want to be mindful of what works in one model might not always work in another. And then the other thing I'll say too is, thinking more along the lines of primary care, we certainly are able to capitate and pay prospectively primary care services or otherwise services, but I think also some of the things we're testing is, if there are supports and tools that we are able to offer at the UPMC Health Plan or able to make UPMC providers aware are available to them more broadly in UPMC, as opposed to prospective payment, maybe if we say, hey, we have a team of practice-based care managers that are able to sit in your clinic, they know intimately well the benefit design at UPMC Health Plan, they know intimately well the structure of this value-based payment arrangement, so they might be more effective than if we had just offered prospective payment and told this practice, go hire more staff if you think that's going to help you succeed. I think if we think more intuitively about the resources that we have to offer, sometimes recommendations might come up that aren't necessarily tied exactly to payment, but we're able to leverage tools and supports up front as well.
Great, Matthew, thank you. So we're starting to wind down here, so I'm going to ask kind of one last question for everyone on the panel. Gosha, I'll start with you on this one. So of all the ongoing initiatives to improve health outcomes and patient experience in your organization, what single initiative gives you the most optimism or enthusiasm, and why?
I am super enthusiastic about the implementation of how the implementation of the payment models goes in the senior-focused primary care. So we have started to extensively study those models. So those are, for those of you who are not familiar, those are your CenterWell clinics that are owned by Humana, but also Oak Street, ChenMed. providers that are implementing this kind of taking on full risks, but also really focusing on seniors and organizing the care around the things that seniors most need. We have seen some amazing results on how effective that care is. First of all, in terms of attracting the historically underserved populations, so seeing definitely much more Black patients, much more dual eligibles served by those clinics, and then also seeing how much it increases amount of primary care delivered to those populations. So like on average, we've seen something like a 16 to 17% increase in primary care in those clinics compared to other providers, similar providers. But among Black population and dual eligibles, it was anywhere from like 25 to 40% increase. So like really encouraged by seeing such a big health equity impact. This is work we're doing together with Harvard, and also starting to see initial data on how that translates into potentially lower need for acute care utilization, and starting to think about intensity of primary care for specific subgroups. So where does it make sense to have the patient in the office once a quarter, maybe twice a year, maybe once a month, like just trying to think about better stratification, but generally really optimistic about the results we're seeing there, and hoping to share some of those pretty soon.
Great, that's exciting. Matthew?
I agree. The patient segmentation strategies are really exciting, and I'm happy to see that they're being implemented and thought of not so much as this is fracturing or creating more silos in care, but providing the very specific needs certain patient populations need. Just very quickly, as I mentioned earlier, the e-consults, I'm very excited about the possibilities of specialty integration. I think the consults is one area where it makes me happy to see clinicians talking to each other and breaking down those silos and helping each other out, as opposed to thinking this is my patient and this is the exact type of services that I work. Also, along those lines, activities around physician profiling and specialty integration, I think, initially at first, so much of it is focused on, is the data right and is the methodology right? But I think the next big, barrier is just implementing this and messaging this to specialists and messaging it to primary care providers on how they're supposed to use this data, how they can interpret it, how they can, improve on their performance. Is another area I think has promise.
I can't believe I'm saying this out loud because there's so many reasons not to say this, but actually,
Go for it.
I'm actually very optimistic about the value that AI, that the large language models will have for us in healthcare, and I say that with all the hesitations of all the challenges and problems that it can create, but I am seeing already that we are able to unlock so much data that's just in our system in text in ways that we can't access it now. We are being able to find in real time people who say that they're giving such and such a medication where there's no medication like that in the order set because we can read the list. We are able to identify immediately high-risk patient portal messages, inbox messages to doctors. We're able to respond to them immediately. We're able to generate summaries that can cross-check against what interns are writing and like sort of help make interns better at diagnostics and at synthesizing data. We are already doing all of this and more live in our health system. I think that this is one of the few areas where I'm actually seeing work reduction sorts of efforts that I think will free up people's time to do like actual clinical care and talking to patients. So I'm feeling pretty optimistic.
Great. Herb, the last word.
I know we're at 0, so I'll make it really quick. I think to me, it's some of the work that we're doing around this new transformation framework and really a focus, at least at the Innovation Center, on more prospectively and systematically assessing the impacts of our models, whether it's quality, outcomes, the care delivery changes, the broader market impacts. I think this is some of the most exciting work, and we've built a foundation over the last decade in the value-based care world to be able to do this. I think it has the real potential to reorient our health system for the end users, for the people that we serve, and honestly, better support those that are delivering care.
Great, thanks. So I heard moderator prerogative today. I'll just say hospital at home excites me, opportunities that are there. So first of all, thanks to everyone for your participation in the panel today, for everyone attending the work. This will really be informative, as all sessions are today, about how we think about our work at the Accountable Care Action Collaborative. I want to give a shout out to the Accountable Care Curve. It's been mentioned before. I encourage you to go to the LAN website and look at the Accountable Care Curve. It's a very comprehensive framework. There's a lot of detail that needs to be worked out with regard to those things, and it's not one size fits all, but it provides a beautiful framework, and it really outlines the work of the LAN going forward. So with that, I'd ask you to join me in thanking the panel.